that, and it causes important psychological problems such as diminished self-esteem, anxiety, embarrassment, and of course relationship problems. How does ejaculation occur? Well, after the initial sexual stimulation here, the sensory afferents bring the sexual stimuli via the pudendal nerve to ejaculation generator, and then it goes up to the medial prooptic area. After the go signal received from the cortex, the signal comes back to the spinal ejaculatory generator, and through the pudendal nerve, ejaculation reflex starts. There is the emission and the expulsion, and then ejaculation occurs. Well, as Dr. Giannini beautifully summarized, there are some oral therapies, and all those oral therapies are trying to fix the brain. It's very distal to the actual action. The actual action is happening in the bulbospongiosus muscle and in the penis. And we are trying to fix the problem from the brain. This is not a very practical approach. Again, my colleague, Dr. Giannini, summarized the importance of antidepressants, which became the major treatment option over the 20 to 30 years. And although there are some other off-label medications, dapoxetin is the first and the only drug which is especially developed for the treatment of premature ejaculation. However, we need to warn you, FDA never approved this medication. Yes, I agree that there are a lot of pharmaceutical companies sponsored trials which demonstrated beautiful, statistically significant outcomes, demonstrating that dapoxetin is associated with statistically significant increase in ejaculation time. However, is it really clinically significant? And yes, the patients are reporting some sort of improved control. How we can assess the control? Via the questionnaires. Are they really reliable? Yes, they are reliable, but we also need to consider that this is very subjective. And yes, the majority of the patients are reporting lesser distress regarding to their ejaculation performance, and the patients are reporting much better clinical impression of change when they are using dapoxetin treatment. So let's return back to the complaints of Mr. Thomas. I mean, he's a 52-year-old man who was abandoned by his first wife due to his sexual problems. And this is his second marriage, a 42-year-old Russian lady who is probably frustrated because of his sexual problems, because she's not coming to the doctor's clinic with him. So poor Mr. Thomas is trying to find a cure for himself by himself. So probably Mr. Thomas will be asking, Doc, are these drugs completely safe? What are you going to tell him? We have to tell him that no, they are not really safe because there are a lot of side effects when you use those antidepressants, such as nausea, dry mouth, headaches, dizziness, and vomiting. Let's remember that he's not that young. He's 52. So these drugs are not safe, and it's contraindicated among patients with cardiac conditions, depression, patients who are using other medications, patients who are suffering from epilepsy, with renal impairment and hepatic impairment. Are we sure that this guy at the age of 52 do not have any of these medical conditions? So what we are supposed to tell him, no, they are not safe for you. Okay. Sorry. Okay, it's not safe, but are they really effective? They are mildly effective. It can increase the ejaculation time to twofold. So if he's ejaculating within 30 seconds, he is going to be ejaculating 1 minute. But let me tell you, according to the definition, 1 minute is still premature ejaculation. Will it be more effective as I use it? Probably he's going to be asking. No, on the contrary, there is a well-established phenomenon called tachyphylaxia, meaning that the efficacy of the medication will be lesser and lesser. That's why the current guidelines recommend to check the patient every 6 months. He is 52 years old. Probably he will be asking, oh, can I also have some erectile dysfunction issues. Will these medications, tapoxetine, will be helping to me with my erectile dysfunction problem? The answer is again no. On the contrary, antidepressants are associated with erectile difficulties and reduced libido. He will be asking that this is my second wife, and maybe she is willing to have a baby from me. I mean, is it okay if he try to conceive a child? No, again, because the SSRIs are impairing sperm cells, spermatogenesis. So probably he will be suffering from some sort of infertility issues, and this will also create a problem between himself and his wife. So he will be asking, Doc, will this drug cure me? I mean, how long am I supposed to use this medication? And this is the worst part of antidepressant treatment. We are going to tell Mr. Thomas that he's supposed to use this medication forever. So I have to warn you that PE treatment needs are unmet. In fact, the patients are also aware of this phenomenon. This beautiful post-marketing study is not conducted by the pharmaceutical company. It's a real-time data. So the majority, the 20% of the patients are saying that, okay, if this is not going to cure me, if this is an on-demand treatment, I don't want to use this medication. 1 out of 5 do not start the medication in the beginning. Those who start the medication discontinue the treatment at the end of first year. So only 10% of the patients, 1 out of 10, will be happy with tapoxetine treatment, and they will be using this medication at the end of 1 year. And here are the reasons for discontinuation: affects low expectations, cost, side effects, loss of interest in sex. So apparently, the oral treatments, SSRIs, are not really effective. So we don't need to fix this problem starting from the brain. Are there any other alternatives? Yes. We can actually fix the problem starting from the penis, where the sexual stimuli start. And actually, topical anesthetics, lidocaine plus pralaquine containing creams, gels, sprays are available. And although there are a lot of controlled studies, I wrote here, but this is the first treatment which has been ever used for the treatment of premature ejaculation. In 1953, Bernard Shapiro recommended the use of topical anesthetics for the treatment of premature ejaculation. Yes, there are some potential problems such as penile hypoanesthesia, transvaginal absorption, which is associated with vaginal numbness, but currently available sprays are decreasing the risk a lot. And current guidelines recommend the use of these topical treatments with level 1A recommendation. If the patients are not really happy by using the gels and sprays, creams, and then wait for a while, and then if he's using the cream, he needs to wash his penis or use a condom. And the majority of the patients are asking for a more permanent way of treatment. Here it comes. I mean, this is a study done by our Egyptian colleagues, and instead of using topical anesthetics to decrease the sensitivity of the penis, they are injecting hyaluronic acid into the glass penis in this fashion with fine needles, insulin needles, and this is associated with decreased sensitivity in the glass penis. And their well-designed, controlled crossover study demonstrated that after 1 of hyaluronic acid injection, there's a statistically significant increase, 2.6-fold increase in ejaculation latency, and the patient is not supposed to use any sprays or any pills, so it's more durable treatment. And it's not irreversible. At the end of 6 to 9 months, the treatment effect goes away, and the patient needs another injection. So it seems like a good, promising treatment. But again, we need to remember that this is a minimally invasive procedure, but it's still an invasive procedure. And in the literature, you can find some catastrophic cases when this injection is not done properly. Okay, so we had glans penis injections and topical anesthetics which have an impact at the glans penis, but there's another region that we can actually intervene to, and this is the bulbospongiosus muscle contractions. Well, this is an idea that we have developed with my colleagues. So we said that if bulbospongiosus muscle contractions are involved in ejaculation, and if we can somehow inhibit those contractions of the muscles, then we can actually have a cure for the treatment of premature ejaculation. In our study that we have conducted in the United States, we have demonstrated that inhibiting the contractions of these muscles with botulinum toxin A injection, we can create a delay in ejaculation in a dose-dependent way in rats. Actually, a more recently published study also showed us that injection of botulinum toxin A into the bulbospongiosus muscles of rats are associated with a delay in amphetamine-induced ejaculations in rats, and this study was also confirming our findings. Do we have any clinical data? Actually, we do, but we cannot reach it yet because the company which used to produce Botox, botulinum toxin A, initiated a clinical study. They have never published their study results, but the results can be found in the clinicaltrials.gov website. And there you can see that some doses of Botox are associated with significant increase in ejaculation time compared to other doses. Maybe these are placebos. And we really look forward to seeing the actual article. We can inhibit those muscles by injecting Botox, but can we also inhibit the contractions, these rhythmic contractions, with something else, such as electrical stimulation? Yes, actually we can. This transcutaneous nerve stimulation, nerve electrical stimulation is a well-established treatment when we use for physical therapy, for rehabilitation in some overactive bladder issues and etc. And maybe we can use these electrical stimulation devices for inhibiting rhythmic contractions of the bulbospongiosus muscle. Well, the medical device company from Israel has developed the initial device long ago, and they have recently published their data, and you can reach the details of this study in clinicaltrials.gov as well. And this is the initial study, proof of concept study, let's say. So they have demonstrated that when they put 2 electrical patches into the bulbospongiosus muscle, they can actually delay ejaculation, and as you can see, ejaculation time decreased almost 3-4 folds when they applied electricity to the perineum of the patients, of the healthy individuals, I'm sorry. So we were asked to convince you which type of treatment is good, oral treatment or peripheral treatment, and I don't know who the winner will be, but let me try to convince you again not to start with oral therapy. There are some other things to do, and oral therapy is not that safe, and there are some new options. And I agree that there is no clinical data yet, but the more we try those treatments, the more we are aware of those alternatives, the better data will become in the future. Thank you so much for your attention.